Welcome to INSITE Chat. So my name is Brad Sellans from Quality Insight. As we've seen on a couple other videos we've been posting over the last few weeks, we're going to do these little mini demonstrations or mini discussions in preparation for the webinars that we're coming up. So one of the other topics that is quite pivotal to what we do is in and around admissions of people coming from the hospital framework or community into residential aged care. So we have a couple of different streams we work with. One being our bed search vacancy finder and portal, communication portal, that we work carefully and in alignment with Carers Gateway across South Australia, Queensland, and New South Wales, and also through our advocacy and resident entry process we do through bed placement and all that sort of stuff. So we also have a lot of links into Resi Aged Care and quite at the coalface in terms of what's going on with the market right now. And a pivotal discussion point is around hospitals and the amount of resident bed blocking that's taking place. So when we define bed blocking, it really is those people that have been deemed to be able to be discharged from acute care setting into a residential aged care setting. They can't necessarily go home because they don't have the capacity or there just isn't anyone to care for them, or they've exceeded what a home care package can do for them. And they typically require the 24/7 care and compliance and well-being that Resi Aged Care does supply people for that setting. When I talk to hospitals and talk to them quite often, a lot of things come up around why patients can't be just automatically taken into Resi Aged Care homes. And there's a couple of reasons for that. And the biggest reason to begin with is the fact that Resi Aged Care homes are filling up, and they're filling up to the point where the vacancy sign, there's no vacancy, goes up quite often, and quite often there's a wait list that is associated with that now. So whereas go back 6 years ago, when I first started in the industry, there was vacancies around the place. You could get into a really good quality home in your local area reasonably easily. You might have had to wait a couple of days or a couple of weeks, but you got in there. Whereas now you could be waiting 2 or 3 months to come into care, and the poor social worker discharge planner at hospital is pulling out their hair because those options are drying up. The other part of what's happening in Resi Aged Care is the funding mechanisms have changed. So it is becoming more onerous or more difficult in assessing residents coming through the door. If that assessment piece isn't on target, it could mean failed placements, which would mean discharge back to hospital, which starts that whole cycle again and really blocks up the whole health network. I would say at a guess, I have no facts or figures on it. This is just purely hearsay, but I would have a guess that the rate of failed discharge back to hospital is higher than it has been for a while. So we've seen and heard a bit of that anecdotally throughout the networks that we deal with. And that comes from lack of communication. And I'll address that as we go through this discussion. The just to the final point around Resi Aged Care homes filling up, there's also a notion now, whereas in the past you had quad beds, tri beds, double shared rooms, they're starting to really dry up, and aged care providers have listened to the market, rightly so, and the market has deemed that they don't want to have their mother or father or loved one in a quad share room anymore. Those days are gone. So it's very difficult to find quad share rooms. But obviously, the more of those beds that come offline, the less capacity Resi Aged Care has to cater for those people. So there would have been a significant number of beds come offline. There has also been not enough beds created. So there have been some care homes built over the last couple of years, but that's really slowed up, mainly because the Resi Aged Care homes are looking at it saying, is it pertinent for them to build any more care homes, given the fact that we're unsure around the new act, we're unsure around how the funding mechanism is going to work, we're unsure can you staff these facilities. So why would they invest in multi-million-dollar buildings to bring that on? So that's created a bit of a vacuum, and the government and the industry has been quite aware of that for a while. So it's nothing new to anyone who's listening here that's in the industry. If you're not in the industry and you're in the acute care sector and you're wondering what's going on, there's probably about 1,000 beds less in the market than there should be, simply because the instability around or instability around where people are at. So there can be some of the reasons why you're not getting the care beds that you used to get. The other piece too, and this has been from again anecdotal evidence, not factually written anywhere that I've seen, but care homes are now starting to take longer to turn around beds, and it comes in a couple of parts. One is having the adequate staff to make sure they can turn them around quickly. Making sure that all their documentation's in order in terms of assessments of bringing people through. I know it's longer than it has been before, and we've got direct feedback from bed brokers and discharge planners that it just seems to take a long time. So it can take up to 3 weeks from when a vacancy is created in the care home to when the new resident enters that home. And it could be other things too, like the upkeep and maintenance has been done, which again is a good thing, but it slows up the process. So for every new incoming resident, if it's taking 3 weeks each time, that is definitely bottlenecking at the acute health network setting. The other bit, and it's probably a little bit more controversial, is the information that has been supplied from the hospital is not necessarily true all the time on that resident. Again, with lots of feedback from different CEOs, different admissions teams, facility managers, and the feedback comes through that the behavioural condition of that particular resident that's been assessed has been exaggerated or understated, which is resulting in mistrust in the whole system and what is being brought through. So I've seen it in first-hand cases where a patient has been presented to come into care, non-smoker, lovely personality, really quiet, get into the care home. They're a 3-pack-a-day smoker and will call out and aggressive tendencies. So those things don't build a good picture from the acute care sector into resi aged care. And what quite often happens is the mistrust builds, and those inquiries that are coming through sometimes fall on deaf ears, where the admissions people and the facility teams will just overlook them. I don't have any particular residential aged care home that has called this out. There are a lot of them that have called this out as a particular issue. So it's something that I'm sure my colleagues in the sector will agree that the better and the more transparent the information, the better and the clearer decisions can be made. I've been in care homes that have taken on extreme conditions, extreme behavior issues. They're all known. Everyone can work out what a care plan can be about, what the different staff training has to be, and everyone's on board, and that person can be looked after. The other part around the aggression and the and people that are presenting with behaviours and needing secure units, the funding model doesn't allow for it. So it actually makes it quite a difficult decision from a revenue point of view and a care minister's point of view, where you've got someone who needs extra help and there is no funding to help with that. So it is definitely a misgiving or a gap in terms of the funding. And we know people smarter than I that are working out these funding models have been made aware of all this, and hopefully addressing that in the near future. But it is a real issue. You've got someone presenting with behaviours. You've got a team that's funded to a certain mechanism or a certain level. There is going to be gaps. There's going to be mistrust, and they're just going to overlook these people moving forward, which is really, really unkind and unfair. The other cohort that seems to be getting missed in all this and potentially bed blocking are smokers. Quite often we'll have to reject people in this industry. The industry is non-smoking. And it's set up for a couple of different reasons. One is to protect the working environment, and rightly so. So from secondhand smoke for staff and secondhand smoke for residents. It's not safe when you've got things like pure oxygen burning in a home. There's a whole heap of mechanisms why smoking is not good. But we're dealing with a generation that smoking is one of the things they did, and really probably one of the last vices that some of these people have got. So there needs to be a bridge built. And again, drawing upon industry leaders to look at how do they address the behaviours and the smoking piece to bring people from the acute care sector into residential aged care and remove that as a factor of concern. I don't know how they're going to do it. I don't have a solution around that. But what needs to happen is it needs to be known what the major issue is. And that's where we enter with Quality INSITE Bed Search. We've developed with Carers Gateway initially and move forward with care providers, a platform or a portal that helps communicate what the real issues and the real need of those particular patients are. So the hospital team would enter into the system. They would identify any vacant beds in the area of care providers that already update us with that information. They would then select the care homes that are appropriate. They would then send off the inquiry, and then through that portal, the communication can take place about what's going on with that patient. What are the additional information that the care home needs to make an informed and correct decision in bringing someone into care. It's all done through a traffic light system and escalation process. And what we can get out of that is we can get a true map or a true assessment on what are some of the more common comorbidities that are going on with people and coming through the acute sector. We know that this process will bring the acute care sector and residential aged care into the modern era. Like it's the automation that can take place, the information that can be fed through to the not only to the care provider but the acute care sector as well. So they've got a really good grasp of what's going on. I know sporadically through the different jurisdictions they've got an idea, but it doesn't appear that they have a holistic understanding. And when we talk to Queensland Health in particular, they don't seem to have a grasp on how many smokers are sitting in hospital that need aged care beds, and then someone actually taking that up, owning it, and going to care providers and saying, "We've got 50 odd people that need to find care home. We need to find a solution around this," and that could take various forms as we run through. Thanks for watching and thanks for listening. I know we can be quite passionate about this area. We will always advocate for the people that need residential aged care, but also admissions people. We find that those people are unsung heroes at times, trying to bring people through into the care setting. They need to be armed with better information, need to be armed with better tools. Social workers and discharge planners are definitely unsung heroes and need to be armed with better tools, and we've got that. And we've also got the passion to help drive and fix these things as we run through. Thanks again. This has been INSITE Chat. We will be having more of these sessions as we go. If you might want to make a comment, please comment. If you find our viewpoint is different than yours, please comment. It's an open forum and when we look at these type of things. Thanks again and have a great day.